and Dr. Jake Bray is here with us. He is a pediatric cardiac anesthesiology at Altner Hospital in New York Medical Center in New Orleans. And so he'll be talking to us about anesthesia consideration in this patient population.
Just click through with the mouse. I'm sorry. Okay. All right. I want to say thank you for you guys inviting me up here. I did all my pediatric and congenital heart training here, and so it's a pleasure being back. So like Dr. Pritchard said, I'm going to talk to you about some of the anesthesia considerations in the univentricular heart. And really, when we talk about anesthesia and the consequences of anesthesia, it sort of primarily revolves around the pathology, first off, that the kid has. And that really sort of dictates the physiologic consequences that we're sort of going to be trying to manage. And whether that's sort of how we affect that physiology from the drugs we give, or a variety of other things like the way we ventilate the kid, which we'll get into here in a little while. And that's sort of true whether or not we're at the sort of pre-surgical repair stage or the first stage, second stage, or all the way over to Fontan completion, which we'll talk a lot about here in a little while. And so when we're sort of talking about Fontans and how they compare to biventricular hearts, it's really important to sort of note that in a univentricular system, there's really only obviously one pumping chamber that inputs sort of kinetic energy into the system. And that's at a time when those sort of univentricular hearts are at an increased workload for those systems as compared to a biventricular system. And so when you look at the hydraulic work that these hearts actually have to do, it's significantly more than a biventricular system at a time whenever they're only able to sort of generate a lower cardiac index as compared to a biventricular system. And so when they sort of pump blood through the circulation, they not only have to overcome the resistance that we normally think of as a sort of typical systemic vascular resistance, but also the resistance of the sort of entire cardiovascular system. And when we think about this from a pressure standpoint, blood comes into the single or the univentricular heart, I should say, is pressurized into the aorta, and then that blood has to flow down a pressure gradient all the way down back to the LA and the univentricle. Or single ventricle. And when we talk about ventilating these patients, it's really at this sort of cavo-pulmonary junction that we really start to affect these things. And so as sort of Jawan was mentioning earlier, during normal ventilation, we create a negative intraalveolar pressure, and which corresponds to a negative pleural pressure, which allows us to both pull air in during normal inspiration, but it also sort of augments the pressure gradient that's generated from the abdominal IVC all the way up into the thoracic cavity, sort of augmenting these patients' pulmonary blood flow. And we change that a lot whenever we start talking about putting these kids on positive pressure, where you create a positive alveolar pressure now, which is corresponding to a positive pleural pressure, and sort of decreasing that gradient that exists during normal spontaneous respirations. And this was looked at recently when comparing normal biventricular hearts to 6 Fontan individuals. They looked at this under MRI while these patients were sort of spontaneously ventilating, and sort of measured the flow through their IVC, SVC, the main PA, and then their corresponding bilateral PAs, and analyzed that throughout the respiratory cycle. And what they saw is that in normal biventricular volunteers, you did see an augmentation of preload, or an augmentation of flow through those structures, but it was greatly exaggerated whenever we look at the Fontan circulation. So in the IVC, they saw an increase of roughly 60%, in the SVC, roughly 25%, and then in the branch PAs, on average, roughly 45%. And not only did they get an increase in flow during the normal inspiratory cycle, but the decrease in flow through the expiratory phase was also exaggerated when compared to normal biventricular individuals. And now from a medical standpoint, we can actually augment this non-invasively through what's called non-invasive negative pressure ventilation through these CRAS ventilators, which is essentially, you can almost think of them as somewhat of like a portable iron lung in a way. And so when you take Fontan patients and hook them up to this device here, it creates a negative sort of vacuum within, or negative pressure within this chamber, and allow them to sort of spontaneously ventilate with this. You can actually augment their hemodynamic variables and stuff. And so that's what this group sort of assessed. So they took 18 patients. Some of them were placed on invasive positive pressure ventilation via ET tube, and then other ones were placed on this sort of non-invasive negative pressure device. And then they evaluated the hemodynamic variables through thermodynamics. And so what they saw was basically that the patients who underwent negative pressure ventilation, they had increased pulmonary blood flow, increased stroke volumes. Their mean PA pressures were lower, their pulmonary vascular resistance was lower, their SVO2 was higher, and then their VO2s were higher as well. And this held true for what they described as their acute patients, which were within a few weeks after surgery, and also for what they described as their convalescent patients, which were a few years after surgery as well. And a subset of patients, they also took a group and had them intubated and on positive pressure. Baseline, they obtained baseline measurements and then switched them to non-invasive positive pressure, or negative pressure, I'm sorry, and then switched them back to a positive pressure mode, and their results still hold true, or held true. But what about the older sort of Fontan patients? This study is on a group of individuals roughly 24, 25 years of age. And then the interesting thing that this group did was they took the negative pressure device that we looked at earlier, and instead of having a set negative pressure of negative 20 or negative 30, what they did was create a sort of bi-level pressure mode, which would correspond to an inspiratory pressure. So the device would generate a negative pressure of negative 27, and during the expiratory phase, it would generate a positive pressure of 7 to somewhat simulate the mild positive pressure that you would see during negative expiration in the intra-abdominal cavity, with the idea of sort of hoping that you would see a improvement in the cavopulmonary gradient. And so they looked at all these cardiovascular variables via MRI. They obtained the baseline measurements with these patients non-sedated, undergoing MRI, and then connected them to negative pressure, their sort of static negative pressure at 30, took another measurement, had a washout period, and then instituted the bi-level ventilation strategy that I mentioned earlier, and went ahead and took another set of measurements. And what they saw, particularly in the bi-level setting, is that within the Fontan circuit, they saw significantly increased flows. Again, in the subhepatic IVC, they saw increased flows as well within the hepatic veins. And the pulmonary blood flow was increased, as well as the cardiac output, particularly so in the bi-level setting group. And interestingly enough, when you ask these patients, how did this make you feel, and would you want to do this again? Subjectively, the patients who experienced the highest increase in pulmonary blood flow and highest increase in cardiac output sort of mentioned that, it felt pretty good. I would like to do that again, which subjectively, it also made these patients feel better as well. And so what about positive pressure, and how do we influence these circuits whenever they come to us in the OR or cath lab or wherever else? And so from earlier studies in sort of the mid-'80s, We know that adding PEEP to these circuits was shown to significantly decrease their cardiac index, and particularly with PEEPs over 6, although there was still a trend to sort of a lower cardiac index as PEEP goes up, but it proved to only be significant when they were, in this study anyways, for PEEPs greater than 6. It was shown to increase their PVR during this period of time and also increase oxygenation. So again, increased oxygenation for these patients while adding PEEP comes at a cost of reducing their cardiac index. And so this sort of brings us to the UPMC group here, which wanted to assess the effect of tidal volumes on these circuits. And in particular, the strategy of higher tidal volumes versus lower tidal volumes. And historically at this institution, we would ventilate these children on a higher tidal volume setting with longer expiratory times and shorter respiratory rates, with the sort of thought that you are limiting your time at higher peak pressures and allowing for more passive flow through your Fontaine circuit. And so to assess that versus a lower tidal volume strategy, they took 30 patients over a period of time that were going to the cath lab. They randomized them into a high tidal volume group and a low tidal volume group, allowed them to equilibrate on that those strategies for a period of time, took hemodynamic measurements, and then transitioned to the other group, and then took measurements again. This is the sort of characteristics of those patients. Most patients were around the age of 10. They all primarily had systemic right ventricles, roughly 70% or so, and 70% as well had normal biventricular function, and the majority of them, 60%, had fenestrations present at the time of catheterization. So when comparing the low tidal volume group to the high tidal volume group, when looking at variables obtained on their ABG, basically their pH, PaCO2, PO2 was not statistically significant. There was no difference in those variables, as well as their hemodynamic variables as well, their MAPs and PA pressures. The only statistically significant variables were the ones that we were manipulating, mainly the tidal volume, manipulating the respiratory rate depending on their what group they were in, and as expected, the peak pressures were higher in the higher tidal volume group. And then when looking at other hemodynamic variables, so QS was not statistically significantly higher in the low tidal volume group, although it did trend to for that to be true. The pulmonary blood flow was the same in both group, as well as QPQS, the resistance at the pulmonary vascular level and systemic level as well. And so what should we really do, and how should we think about these patients whenever they present to either the OR or cath lab, or for any sort of outside area procedure? I think it's sort of appropriate to assess these patients for the need of either mild to moderate sedation while maintaining spontaneous ventilation. Although I don't think that should come at a cost of potentially either risking an airway complication or risking sort of having to instrument the airway emergently. And so I think if you need to intubate these kids, I think that's fine, and more appropriate a lot of times than not. But having in the back of your mind what the cost of intubating those kids are, and having a strategy to deal with your method of ventilating them. So I would suggest moderate tidal volumes with avoidance of larger tidal volumes. Limit PEEP as much as possible. Adjust your respiratory rate to maintain physiologic parameters. And consider lengthening your E times as well, your expiratory times, and sort of adjusting your FiO2 as needed, with the goal of getting these kids extubated in the OR, if at all possible, are setting them up to extubate as soon as you get to the ICU if you're concerned that they need more invasive respiratory support that you couldn't provide in the OR. So thank you.